Living longer, living healthier, living better than ever before. Welcome to Mountain Pacific's Healthy Living for Life, a weekly series that gives you the information, education, and expert insight you need to become an active participant in today's ever-changing healthcare climate. Here now is today's program host.
Have you ever heard of a superbug? Many times when we talk about something being super, it's a good thing. But superbugs are becoming one of the world's most pressing public health issues. Today we're talking about bacteria, or bugs, that can make us very sick and no longer respond to even the most powerful medications we have to fight them. So what can we do about it? I'm your host, Beth Brown. Welcome to Healthy Living for Life, a show dedicated to helping you do just that. Stay tuned, we'll be right back. Welcome back. Since the 1940s, antibiotics have greatly reduced illness and death from infectious diseases. But these medications have been used so widely and for so long that they're becoming less effective. Each year in the U.S., at least 2 million people become infected with bacteria that are resistant to antibiotics. I'm joined now by Dr. Donald Skillman and pharmacist Tom Richardson, who are going to help us better understand the public health issues surrounding the overuse and misuse of antibiotics and how we've contributed in the creation of superbugs. Thanks so much for being here this morning, gentlemen. So Dr. Skillman, let's start with you. Can you just tell us what we're talking about here? What are antibiotics?
Antibiotics are medications that we use to fight infections. And infections are caused by microbes. Those microbes, we usually call them germs. Those can be bacteria or viruses or fungi. And it's a different class of medication that's used to kill each type of organism like that. So the antibiotics that we're most familiar with are the ones used to kill bacteria because those cause the most common types of infections.
Okay, and so Tom, what happens if we take antibiotics when we don't need them?
So one of the things that we've seen nationally is that we have had issues with overutilization of antibiotics. And what we've seen is that bacteria have become resistant to a lot of the traditional classes that we've used throughout the years. And as this continues on, the bacteria get more and more resistant, really limiting our options to be able to treat infections, and really puts healthcare providers in a bind to when patients come to the hospital or come into the clinics that need antibiotics. A lot of those no longer become effective treatment regimens.
And how does that happen? How do they become resistant?
Yeah, that's a really good question. Bacteria are really old. They're billions and billions of years old. So they've been on Earth longer than we have, and they've developed really sophisticated resistance mechanisms. And as we've used more and more antibiotics, they're able to really adapt to seeing and having exposure to those antibiotics and upregulate genes, which eventually leads to them being able to ward off any antibiotics that come their way. And as overutilization occurs of giving too much antibiotics, we see this becoming more and more of a problem.
And national and even worldwide organizations like the CDC, the FDA, the World Health Organization, they're talking about how antibiotic resistance is becoming a huge public health issue. What are the effects? Why is this such a huge concern, not only in this country, but around the world?
Well, when you get a resistant type of infection, it's much harder to eliminate. So we often find people in the hospital for longer time intervals. They may be much more sick. Instead of so sick, they're deadly sick. We need to use the more expensive antibiotics that often have more harsh side effects. And so the hospital bill is higher, the patient pays more money, they're in the hospital longer, and their survival is lessened also. These highly resistant bacteria can be so difficult to kill that they can kill the patient before we can kill all the germs.
Wow. And there are several strains of antibiotic-resistant bacteria out there. What are some of the biggest threats that we have right now when it comes to antibiotic resistance?
There are a lot of threats out there, you're right, and the CDC does surveys nationwide and worldwide to see what the big ones are. The leading one in America right now is a bacteria called Clostridium difficile, or C. diff. It's a germ that lives in a lot of people's intestinal tract, and when we give those people antibiotics, the antibiotic will kill the majority of the germs, but the C. diff will stay behind and have a great day because all the competition is gone. So it rises to a huge population and causes just a horrible diarrhea. In some circumstances, it's a very deadly diarrhea. And that is becoming increasingly difficult to cure. We find a lot of people who need several courses of antibiotic therapy before we can eradicate it.
Are there others that people should be aware of?
Yes, some of the other big ones that are resistant are tuberculosis on a worldwide scale, streptococcus, and we probably all heard of that staph called MRSA, which is methicillin-resistant Staphylococcus aureus. That requires a variety of expensive antibiotics to kill. Staphylococcus is a very aggressive bacteria. It can kill people easily. It can get into the bloodstream and spread to heart valves and bones and the brain. So we take that one very seriously, and we put people in isolation when they have that in the hospital.
Okay. And Tom, maybe you could take this one. It seems like the obvious question here is, why can't we just make more, bigger, better antibiotics to battle some of these superbugs?
Yeah, and I think that's a really interesting question. Just to kind of, again, going back to the history of this, antibiotic development has really kind of come to a halt. In the 1960s, methicillin was developed and created and introduced into clinical practice. And within 3 years, we had methicillin-resistant strains of Staph aureus, or as everybody now knows it as MRSA. And so we're always kind of lagging behind once these come out. We really have a 2 or 3 year window where antibiotic resistance develops. So we really have to develop antibiotics at a rate that really exceeds anything that we've been able to do to this point. As the years have gone on, development's become less and less profitable for pharmaceutical companies. And we've seen that. We know that in the 80s, we used to have dozens of antibiotics come to market. There were a lot of novel entities that were introduced. And as time has gone on, and especially in the 2000s, we're lucky if we get 1 to 2 new antibiotics that come to market and we're able to use in clinical practice. And not all of those are always helpful in treating these resistant organisms. So really, I think that, with some of the newer stuff that's gone on, there's been a lot of fast track approvals, what we call it, where antibiotics and research and development from pharmaceutical companies, there's now an easier path for them to develop these. It's less costly for pharmaceutical companies, and it has shown behind the scenes that there are more in development and are in phase. They go through clinical trials, as a lot of us are familiar with, and that there are a lot of more in clinical trial phase right now that hopefully in the next 3 to 5 years we'll see more of an influx of, again, agents that are helpful in treating these resistant infections.
Okay, and we're almost out of time, but you talked about the cost of developing antibiotics. What about the cost of antibiotic resistance?
Yeah, that's a great question. And as Dr. Skillman alluded to, these infections are more difficult to treat. They usually require us to use more costly, broad spectrum antibiotics. And so anytime we have these infections, patients are staying in hospitals longer, which certainly increases costs to patients, to healthcare entities. And then again, those antibiotics that we use, where a lot of the old school drugs we're able to use are pennies on the dollar, and these newer, nice, big, bad agents are, thousands of dollars per course. So again, that resistance really drives the increased costs.
Okay, thank you, gentlemen. So superbugs are the bad news. Is there good news? Yes, there is, and we'll talk about that when we come back right after this. Welcome back. Antibiotics are important drugs. There's no arguing that they play a big role in treating infections, but they have to be prescribed and used correctly to continue to have a benefit on our health. Tom Richardson is still with me, and joining us now is Heidi Simons. Both Tom and Heidi are pharmacists who are going to talk to us about how healthcare providers are working to fight antibiotic resistance. So thanks for joining us, Heidi, and welcome back, Tom. So Heidi, let's start with you. The biggest weapons, if you will, that we have against antibiotic resistance is antibiotic stewardship or antimicrobial stewardship programs. Can you tell us a little bit about these programs?
Sure. So antimicrobial stewardship is a very broad term that encompasses both inpatient and outpatient programs to help improve selection, dosage, and duration of antibiotics. This is so that we can get the best treatment outcome possible while producing little to no toxicity to the patient and having little to no impact on bacterial resistance. So it's kind of a big term, and it encompasses a lot of things. So we do this by having dedicated reviews of each patient on antibiotics every day and making sure that that's appropriate for what infection they have, making sure how long they're treated is appropriate and they're not unnecessarily taking antibiotics when their infection's been treated, and using the most narrow spectrum agent possible. So not using a cannon to treat a mosquito bite, sort of a thing. We help provide feedbacks to our physician providers on how they're prescribing to help them improve their prescribing habits. We provide a lot of education, educate our nurses, educate our physicians, and our patients to help incorporate the principles of antibiotic stewardship into daily practice and make it reflex as opposed to something to work at. We also work closely with our colleagues in the microbiology lab to track our bacterial samples to see where our resistance patterns are going. If we don't track how resistant our bacteria are, we don't know which antibiotics we might be losing in terms of being resistant, for lack of a better term. Another important point to make is that stewardship involves everyone. So it's not just an antimicrobial stewardship pharmacist or physician, it's all of us. It's all the staff at the hospital, people in the clinics, and our patients. It's a group effort. And the core team, of course, involves an ID physician and an ID-trained pharmacist and microbiology expert and an infection prevention expert, but really it's everybody. And using these programs to combat bacterial resistance has become a national priority and a patient safety issue. So antimicrobial stewardship programs have been shown to reduce unnecessary antibiotic use by 20 to 50% and reduce patient length of stay in the hospitals by 1 to 3 days on average. We can also decrease community-wide resistance rates and keep our facilities compliant with regulatory bodies. So there are a lot of benefits. And in 2014, the CDC recommended that all acute care hospitals have one of these programs, and hospitals are doing that nationwide. But now stewardship programs, as I alluded to, are not just in hospitals, but also in clinics and in the emergency departments where most of the antibiotics are prescribed.
You started out talking about inpatient and outpatient programs. For those folks who don't know, what's the difference?
Sure. If you're officially admitted into a healthcare facility, you are quote unquote an inpatient. Any care you receive during that stay would be considered an inpatient service. So if you're staying in a skilled nursing facility or a nursing home or staying in a hospital, that's all under an inpatient stay.
Okay.
You're outpatient if you're getting care at an emergency room or an urgent care clinic, or if you're just seeing your doctor in the clinic, or if you have surgery but only go in for the procedure. So anything under those kinds of stays would be considered outpatient.
Okay. And Tom, are most antibiotic stewardship efforts happening in the outpatient setting or no?
So I would say the greatest need is in the outpatient setting. If we all sit here and conceptualize, more patients visit outpatient clinics, more patients see their providers for non-acute illnesses and infections that aren't severe enough for them to go to the hospital. They go to their primary care provider and seek treatment, which a lot of time results in antibiotic prescribing. So in the outpatient setting, we see more consumption of antibiotics. However, right now, and traditionally, the focus has been antibiotic stewardship programs in the hospital because that's where we see patients come in with those really resistant bugs. And we first recognized that this was going on, that those patients were coming in really, really sick, and we didn't have enough to treat them. And as we traced it out, we figured out that as we were using more antibiotics in the community, that's what was really driving a lot of this problem. So the greatest need certainly is in our outpatient antibiotic stewardship arena. That's the big push nationally right now, is to tackle that. But as it stands, it's more common in the hospitals. But I think in the next 5 to 10 years, that'll be a 50-50 split, hopefully.
Okay, and let's talk about prescribing antibiotics for a minute. Why do they get prescribed when they're not needed?
Well, I think that's kind of an interesting question. Literature in medicine changes all the time. We get more information. There's new guidelines that are published. Within the last 10 years, we've found out a lot more about resistance, about what's driving resistance, about how better to treat infections. We know a lot of the acute upper respiratory infections, for example, when you have common colds, or most of the time are viruses, and we've had more literature published and guidelines that help clinicians now know more that that you can wait to get that antibiotic, or that certain symptoms coincide with more viral versus bacterial. So I think that traditionally we've seen prescribing driven because we just didn't have a lot of this information. As more and more comes out and we educate our patients and our providers and everybody more and more, I think we're in a better situation to actually tackle this.
And you talked about education, and that's a core element of antibiotic stewardship. What are some of the other things that healthcare providers are focusing on for antibiotic resistance?
I think one of the big ones is allergies. Patients a lot of times will state that they have a penicillin allergy, for example, and we know that very commonly it's stated somebody has a penicillin allergy, but we know nationally the true rates of penicillin allergies are less than 3%, and the severe ones are less than 1%. So that's something that we're focused on, because when we can't use that class of drugs, we have to use the bigger spectrum antibiotics, which again, we're trying to preserve those.
And many people are thinking, well, that's great. These people have antibiotic stewardship, but how do you actually operationalize it? And the CDC has given us core elements of stewardship programs for how actually to do this. And as you said, it includes a lot of education, but it also includes commitment, getting commitment from your senior leadership in either your clinic or hospital, trying to incorporate this into your daily policies and ordering protocols so that, again, it's reflex and not something you have to think about. And then tracking and reporting to make sure that you're actually watching tracking your prescribing practices and tracking your resistance patterns. There's a lot that goes into it, but there are resources available.
Okay, great. And we are out of time. So now we know what healthcare professionals are doing to help battle antibiotic resistance and superbugs. What can you do about this? We'll talk about that right after this. Thanks for staying with us. As we've discussed, antibiotics are strong medicines, but they don't cure everything. And when they're not used correctly, they can actually do harm to your health and to the health of people around you. You play an important role in your own patient safety, and helping fight antibiotic resistance can help keep you from getting a superbug. So how do you protect yourself and your loved ones? Heidi has stuck around with us, and Dr. Skillman is back. Thanks again for being here today. So Dr. Skillman, let's start with you. When somebody gets sick, what they're most concerned about is just feeling better as soon as they possibly can. We now know that antibiotics only work with with bacteria, not with viruses. So if someone does have a virus, what can they do to feel better?
There's a lot of products you can purchase in any good pharmacy that can help you feel better. Some decongestants, things like acetaminophen to reduce the fever and the general body aches. We know that gargling with salt water can help a sore throat a lot. And there's even some good scientific studies that show honey in a cup of tea can reduce coughing and make your throat feel a lot better.
Okay, and how does somebody know if they're sick with a bacteria or with a virus?
That can be quite difficult, actually. They both can cause fevers. They can both make you feel miserable and give you pain in various locations. Usually a bacterial infection will cause pus or some kind of ugly fluid if it's in the skin or in your lungs. You may be coughing up more ugly junk than a virus would produce. But it can often be quite difficult to tell the difference between them.
Okay, and if I find out that I am sick with a bacterial infection, then if I get an antibiotic, how can I be a good steward of that prescription?
You can talk to the doc who prescribes it to you, or the health provider. Often it's not a doctor, and just ask them if it is exactly the right antibiotic and not one that's unnecessarily broad. You don't need to kill all the bacteria in your body, for example, just the ones in your throat if possible. You can ask about side effects of the antibiotic. You can ask about interactions with your other medications, maybe with alcohol if you drink on a regular basis, things like that. You want to take the entire prescription that the doctor or the health provider prescribed. Don't stop too soon. And don't treat yourself. Don't go to your medicine cabinet and find something left over from a previous illness. And when you shouldn't have any left over if they were prescribed correctly. But if you are at the end of your 7 or 10 days of therapy and you have a few pills left, you should discard of those carefully in the solid garbage. Don't put them in the water supply.
Okay. And dentists sometimes prescribe antibiotics as well. Are there things we should know if a dentist is doing the prescription versus a doctor?
Very similar things, actually. Sometimes dentists will have insight on some solutions that you can gargle with or rinse your mouth that can eradicate infections that involve the teeth or the mouth. But dentists are awful bright people in general, and they do a pretty good job with antibiotics.
Okay. And in addition to just being good stewards of antibiotics when we do get those prescriptions, how can people just avoid getting an antibiotic-resistant illness or infection in the first place?
You can avoid the resistant infections the same way you avoid all infections. The main thing is to wash your hands. Do that carefully with soap and water or one of these hand gels that come in little bottles, or you find them stuck on the walls of healthcare facilities. Those don't work as well as a good 20-second hand wash with soap and water. The soap is the key component. The water doesn't have to be warm or hot, just some good soap on your hands and around the fingernails and knuckles. You want to ask your visitors that may come to see you in the hospital to wash their hands before they enter the room and touch you and before they leave the room, because we don't want them carrying your germs around the hospital and around town. If you go to public places where there's handrails and doorknobs, wash your hands now and then before you have lunch, for example. That's the real common way to put bacteria into your body, is through eating something or touching your mouth after you've got it on your fingers without any knowledge of it. You won't see the germs on your hands, but you'll scratch your eye or pick at your tooth or fingernail and get a bacteria that way.
And you mentioned washing your hands if you're visiting somebody in the hospital. And we know that the hospital can be a source for these antibiotic-resistant bacteria, and they become what's known as healthcare-associated infections.
That's right.
Can you talk a little bit about how to keep people safe from those kind of infections when you're in the hospital?
We use isolation procedures for people when they have a recognized highly resistant bacteria, or a virus for that matter, where they're in a room that the visitors must wear gowns and gloves and sometimes masks to go in the room. Occasionally we have trouble getting the visitors to cooperate with that, and we have to become stern with them. Ideally, not just the nurses and docs and physical therapists would gown and glove that way, but all the visitors would. That's the best way to prevent carrying those resistant organisms out of the patient's room and into the hospital, and the elevator buttons and every doorknob between the room and the outside world. So we ask our visitors to be good stewards of hand hygiene.
And if I were going in for a surgery, for example, and I know I'm going to be prescribed an antibiotic, what should I do to help stay as healthy as I can for that sort of situation?
If it's a planned surgery, something that's not emergent, we have to remember that infections don't just occur in the operating room or the hospital, but it's the several days before the procedure and the several days after. It's a full spectrum of opportunity to get an infection. So you take care of yourself before you come to the hospital with careful bathing, maybe sleep in clean sheets on a clean pillowcase the night before surgery, wash your whole body carefully with good soap. The medical team will do their job while you're in the hospital, but after you leave the hospital, if you've had surgery especially, don't let your cat walk on yourself, or your dog lick your bandages, or your parakeet sit on your shoulder that was just replaced, things like that. We see things like that occasionally, and it's disturbing, but it's real. So keep the wounds clean after surgery.
Okay, and we've given out a lot of information. Heidi, if anybody has any questions or if there's more that they would like to know, are there resources they can go to just really quickly?
Absolutely. The CDC has put out some great recommendations for patients, and that can be found as part of their Get Smart campaign. So if you just go to their main webpage, there's a lot on antimicrobial resistance, but there's just a lot of patient education pamphlets and tidbits that would be helpful for people.
Perfect. Great. Thank you so much for all your information. And thank you to Tom, too, for being here. And thank you for watching. That's all we have for today. We hope you'll be able to do your part to fight antibiotic-resistant superbugs, and most importantly, that you will stay fit, stay well, and stay healthy for life with Healthy Living for Life. Until next week.
Healthy Living for Life is brought to you by Mountain Pacific Quality Health. We'd love to hear from you. If you have suggestions for future programs, visit our website at mpqhf.org or call us at 406-443-4020. You can also catch us on YouTube by visiting our website and clicking on the YouTube icon. Special thanks to Fire Tower Coffee House and Roasters. Production facilities provided by Video Express Productions.